So let me introduce Sophie Stocker. She is a senior lecturer at the University of Sydney Pharmacy School, and she is a very active collaborator. She also has an honorary position as a senior hospital scientist at the Department of Clinical Pharmacology and Toxicology at St. Vincent Hospital. And I work together with Sophie on several projects. And she has a research program that involves clinical and experimental pharmacology, ethnopharmacology, pharmacogenomics, pharmacometrics, qualitative research on the impact of intrinsic and extrinsic factors on drug deposition, efficacy, and safety. Her research focuses on understanding variability in response to medicine and how this can be managed to optimize patient care. So that's a lot of research, Sophie. But now you're going to talk about the use of biosensors for in-situ measurements of antimicrobials. That sounds very exciting. Sophie, the floor is yours.
Thanks, Jan-Willem, and thanks for the organisers for the opportunity to speak today. And it's unfortunate I couldn't make it up to Brisbane in person, but the next best thing is to obviously present online. I'm going to talk to you about an area of research which is relatively new to me. So I've only been working in this space for the last sort of 2 years, but I think it's a really exciting space to be working in. And I hope that by the end of the presentation, I will have convinced you that the potential for there's definitely a potential for biosensors to facilitate precision dosing and therapeutic drug monitoring. So I'll just start with my disclosures. So I consult to a number of companies, and particularly for this talk, my consultancy for Nutromics is relevant. They're a company here in Australia that's developing a commercial biosensor, and I also sit on some scientific advisory committees. So it's not a surprise to this particular audience, but there is definitely the main reason why we conduct therapeutic drug monitoring is because response to medicines differs so much between individuals. And as really nicely articulated here in this figure, there are therapeutic classes of agents where response is really quite poor, and then obviously response between individuals is particularly substantial. And this really suggests that a one-size-fits-all approach is not going to be appropriate between individuals. And whilst there are many factors that contribute to this variability in drug response, intrinsic factors such as genetic variation, changes in organ function, and extrinsic factors such as drug-drug interactions or environmental interactions, it's really important that we consider this to enable us to optimise therapeutic drug monitoring or optimise the use of medicines. So there's a number of challenges with the sort of traditional approach of therapeutic drug monitoring, and one of those is really the turnaround time of drug concentrations, and this can really impact the ability to make informed clinical decisions in a clinically relevant time frame. In large cities that are well resourced, such as in Sydney, Australia, and there are a number of fantastic bioanalytical services that ensure that this turnaround time of drug availability of drug concentrations is reduced. But this is definitely a challenge, particularly in more resource poor settings or in more regional, remote regions of the world. And also it's difficult to establish, and then obviously it's difficult to maintain a bioanalytical service, particularly if you've got some chromographic techniques that the laboratory delivers. This can be quite resource intensive. In addition to these aspects, there's also difficulties with the therapeutic drug monitoring process itself. So we know that in routine clinical practice, it's quite challenging to collect a sample at a specific time within a dosing interval. So previous work at St. Vincent's Hospital indicates that less than 20% of vancomycin concentrations are actually trough concentrations. And this issue with the inability to collect or the difficulty with collecting timed blood samples has been articulated worldwide, and I think it reflects both the busy clinical environment, but as well as the fact that the institution infrastructures and systems are not necessarily set up for us to be able to collect specifically timed samples. For example, at St Vincent's, most of the therapeutic drug monitoring samples are collected by phlebotomists, and they have a really routine structure where they move throughout the hospital collecting these blood samples, and they actually don't have access to the electronic monitoring software where they would be able to find out when that drug was last administered to the patient. So really being able to identify these system failures to be able to collect time samples is really important. Even when we use more sophisticated approaches, so when we use dose prediction software, which can overcome some of these challenges and you're no longer required to collect a specifically timed sample, the predictions of drug exposure or drug concentrations using software really depend on the quality of the data put into the software, and I and others in this space have looked at inaccuracies in the time of drug administration, inaccuracies in the time of sample collection, as well as the potential impact of inaccuracies in the dose administered on the accuracy of the predicted drug exposure, and all of this can impact the doses recommended to individuals. And often the use of this software requires specific expertise, and there is then this behaviour change or this shift to make dosing decisions based upon those recommendations produced by the software. So, and I think some of the speakers later on in the program today, finally, one of the main challenges is conducting therapeutic drug monitoring in the outpatient setting. And this is really challenging, and particularly so in a country like Australia, which is a huge country and has got large regions of remoteness. Just to put it into perspective, because I know we've got an international audience here today. So one of the largest cattle stations in Australia, in South Australia, is actually that single property is larger than Israel itself. And we need to develop approaches to enable us to deliver therapeutic drug monitoring in these types of regions and at least rural, remote regions of the world. And that's currently challenging using traditional approaches, but definitely becoming more possible as some of these microsampling approaches have been implemented throughout the world and in different therapeutic settings. So finally, irrespective of the method of sample collection or where you're located in the world, at the moment we're making drug dosing decisions often based on a single drug concentration in a particular point in time. And it really doesn't give us a very detailed picture of drug exposure in that individual. Yes, we've moved forward in terms of with the use of dose prediction software, we can predict what drug exposure might be. But if you don't have access to dose prediction software, you're really asking the clinicians or the pharmacists to do a lot of guesswork in terms of being able to predict themselves what the drug exposure is in that individual. Of course, in an ideal setting, we actually would like to be able to measure drug exposure and not have to predict it. And this, of course, is the ideal scenario where we would have this real crystal clear picture of drug exposure in an individual. This is where I really think that biosensors have got a role in moving from this snapshot viewpoint into this, this measurement of drug exposure. And coupled with this is really this segregation of the patient from the bioanalytical processes. And currently, this is often the patient is far removed from the bioanalytical processes, and that contributes to the turnaround time issues. But I think that can also be improved potentially with the use of biosensors. So biosensors are not new. We're actually very familiar with probably one of the most famous biosensor that's been used in clinical practice, and there's these continuous molecular monitors for glucose or CGMs. And these biosensors use an enzymatic detection of metabolites, and there have been other biosensors developed for other compounds. But glucose is by far and away the most common wearable biosensor that's used currently. And its impact on improving patient outcomes has been well established. And recently in Australia, actually just in July this year, launched the National Diabetes Service Scheme, which subsidises the use of CGMs for diabetic patients. So really reflecting this ability for continuous monitoring of compounds to improve patient outcomes. So we've been able to do this for endogenous compounds, and so really what I'm interested in is whether we can use this approach to continuously monitor drugs and drug molecules, and thereby use that continuous molecular monitoring to make informed decisions about the way that we use medicines. So biosensors can be classified into several different categories and according to their bioreaction. So we can use antibodies, bacteria, DNA, enzymes, or membrane receptors to instigate that response for the biosensor. So after you've created that reaction, then of course you need to produce a signal, and there are different ways that we can detect that signal, but by far and away electrochemical and optical detection or output methods are the most common. And throughout the talk today, I'm going to talk to you about predominantly electrochemical detections or outputs. So there's been a number of biosensors that have been developed, and essentially these are almost like miniaturized laboratories. And this is one of the most recent miniature lab biosensor that's been developed. So this biosensor, again, like the CGMs, utilizes an enzymatic reaction. It's an antibody-free reaction. And here they've illustrated the effect of this biosensor with PIPTAS, so piperacillin tazobactam. And they've collected samples in different matrices, including exhaled breath or air. And essentially they can use this microfluidic biosensor, which has this enzymatic reaction, and they, collect a sample, pop it onto the biosensor, and then from there they can determine the concentration in that particular matrix. The turnaround time is less than an hour, so essentially you could sit beside the bedside or very close to the patient. It has the ability to multiplex, so you can use or detect multiple analytes. And this particular study, they looked at piperacillin tazobactam and meropenem and could distinguish between the two compounds. And obviously it has the advantage that you can collect different matrices as well, which might have additional therapeutic benefits depending upon the agent or the drug, as well as the indication for that particular drug. So I think this is a nice example of how biosensors can become these sort of mini laboratories, but it's still not the ideal case where we're still getting a snapshot in time. Probably more relevant to the microsampling is the use of biosensors to detect antibiotic concentrations in really small volumes of interstitial fluid. So here I'm talking volumes of less than 1 nanoliter. And essentially these biosensors use these tiny microneedles. It sits onto the surface of the skin and just goes into the interstitial fluid. So just the surface of the skin before you hit that capillary bed. So again, these biosensors use an enzymatic reaction to detect, in this particular instance, vancomycin concentrations with an optical detection method. And essentially, this is now on body, but still extracting a matrix. So it's not quite in vivo yet, but I think at least a step forward from this biosensors as a miniaturized lab or point of care testing. So whilst these particular methods can help reduce particularly that turnaround time, and at least with the microneedles are on body and less invasive than blood sampling, they still at best give you a couple more concentrations in time. And so the picture, whilst less fuzzy, is still fuzzy, and we still haven't hit that ideal scenario which we have with continuous glucose monitors, where we have that full picture of drug exposure. So can we use biosensors for continuous molecular monitoring and really emulate that CGM approach? So this has been done previously. Tim Rawson and the group at King's College in London have produced a patch, a biosensor patch that uses these microneedles. It sits on the surface of the skin, and using an enzymatic reaction, they've been able to detect phenoxyl methyl penicillin concentrations in the interstitial fluid. So essentially, the way this particular biosensor works is this enzymatic reaction converts the penicillin to penicillate plus a proton. And that proton then, as the protons accumulate, has this change in pH. So essentially, the sensor is detecting this change in pH and then converting that to a concentration of the drug. So this has been tested on body in 11 healthy subjects that were dosed to steady state, and then the concentrations in the interstitial fluid from the biosensor were compared to concentrations from microdialysis, which is the light blue data, and that's considered the gold standard for extracting interstitial fluid. And you can see that the concentrations from that microdialysis and the biosensor that's sitting in the interstitial fluid are really similar. So I think this is a very exciting advance in the biosensor space. Essentially, this is for the first time showing that real-time continuous monitoring of beta-lactams is possible in humans. I think probably one of the limitations of the sensing approach is the fact that it relies on this pH change, and as many of our critical care physicians know, that in critical care there's often acid balance fluctuations in patients, and it's unclear how that might impact the functioning of this particular biosensor. And again, it still relies on an enzymatic reaction, and that's not necessarily going to be appropriate for all types of compounds. And so that, I think, in my view, limits this particular approach, although it definitely is a step in the right direction. So based upon these limitations, I think one of the most exciting potential opportunities in the continuous molecular monitoring space is not necessarily using this enzymatic or pH-driven signal, but actually using Aptamer sensing principles. So this is a sensing principle which is analogous to what's happening in vivo in the biological sense. And essentially what the premise is that a DNA sequence, which is specific for a particular target, can be synthesized with a reporter or a redox reporter at the end here, which is usually methylene blue. And essentially this DNA sequence can be engineered so that it undergoes a binding-induced conformational change. And once it hits its target. And essentially that means that from a low electron transfer to the metal gold electrode, once it has this conformational change, you have this rapid electron transfer once it's hit this target. And this can be detected using simple voltammetry. And then you can see the current change when the sensor, the Aptamer sensor, has bound with the target and when it hasn't. And the beauty of this particular approach is that it's independent of target reactivity. Yeah, and unlike your enzymatic reactions, which require this chemical change, this particular approach doesn't. And essentially you could create DNA aptamers for any target. And that's indeed what has happened. So there's been a number of aptamers developed for drugs, but also metabolites and toxins and biomarkers. And I think this is the real exciting aspect of this particular approach, is that now we are no longer just in the realm of drug molecules, but we can also transcend to other particular compounds, including biomarkers. And the ability to multiplex or measure multiple analytes on an Aptamer biosensor means that we can actually pair drug molecules with their appropriate biomarkers. They may be biomarkers of efficacy or toxicity, as well as potential metabolites, which may also give us a better idea of the overall picture of how a particular medicine is working in an individual. And the ability to monitor drugs, metabolites, toxins, and biomarkers is currently not possible with any of the other approaches to detecting compounds. So the use of this Aptamer technology is very precise, and it can accurately detect concentrations. So here we've got different concentrations or ascending concentrations of vancomycin. This is in vitro data from undiluted whole blood, and as you can see, as the concentration of vancomycin increases, that increase in concentration is detected by the biosensor, and the precision and accuracy is better than plus or minus 10%. So definitely the accuracy is within the realm of our current bioanalytical methods. The sensor is also stable and can continuously monitor drug concentrations at least for 24 hours. And my work with Nutromics indicates that these sensors are stable for up to 5 days. So here you can see that sensor is in situ. This is in a rodent setting. And, you know, we've challenged with a particular concentration of vancomycin, and the sensor can detect this concentration just as accurately after 24 hours. So this really indicates that the use of these types of continuous monitoring lends to this once a day application, and maybe even longer if we can indicate that the stability of these sensors can go out to 5 days. The sensors can also support continuous monitoring in vivo. So this is data from doxorubicin in a rat model, and you can see over at least a 5-hour period, the sensor is able to detect multiple administrations of doxorubicin really quite clearly. It also gives you an idea of the granularity of the data that's produced. And I think probably one of the figures that excites me the most about this particular biosensing approach is this particular figure here. So here you can see tobramycin concentrations being detected by the biosensor. This is in both female and male rats, and the sensor is placed here in the jugular vein. So it is the concentrations are a little bit more fuzzy. But as you can imagine, the jugular vein is quite a noisy environment. And one would anticipate that the use of this biosensor in the interstitial fluid space in humans would result in much less variability in the concentrations. But I think what's really striking here, and what we've always known, is the variability. So this is between the rodents. So it's the same concentration or same dose of tobramycin in the same strain of rats. And you can see that in these 12 different rats, the concentration time profile of tobramycin is really variable. And I think this is the real, I guess, change in thinking, that with the use of this biosensor and continuous molecular monitoring, for the first time we can actually measure drug exposure in real time and continuously with granularity like we've never seen before. You know, if you think about the types of studies that we do in drug development, where we collect intensive blood samples, we might collect 10 or 12 samples in a dosing interval. And this is just thousands of concentrations collected over time. So this data is so granular that actually recently I've worked with both Professor Plaxo and a really clever PhD student mathematician, so Matthew McDonough, and we've actually used the data from these rodents, so this tobramycin data, and we've actually been able to use that data to describe time-varying changes in pharmacokinetics. So it might not be, you might not be able to see from these particular figures here, but when you actually zoom into the data, you can see that the renal function of the rodents was changing over time as the anesthetic was wearing off. And we can actually detect that, those subtle changes in renal function using this really granular data. And essentially this granular data is more informative than some of the more mathematical and intensive approaches to describing drug exposure. And I think particularly in the critical care setting, where we have really quite dynamic physiological changes which really impact drug exposure substantially, this particular approach is really exciting. And then finally, you know, with this understanding that the use of Aptamer Biosensors approach is accurate, precise, and continuous, and we do then have this potential for these closed loop systems or feedback control systems. And whilst this is not yet a reality in the clinical space, this has definitely been shown to be possible in the preclinical space. And then here we have some nice images of intravenous tobramycin administration, again in a rodent model. And we can see that once we start the feedback control with a sensor response infuser, we can really keep tobramycin concentrations in a very narrow concentration range. So highlighting that we may not be too far away from control feedback dosing of medications with the use or implementation of biosensors. And finally, the data I've showed you previously has been predominantly in rodent species, and there is currently not a commercial biosensor which utilizes this Aptamer technology available. But I am working with a company that's down in Melbourne called Nutromics, and they are indeed have this vision to develop a patch that has these microneedles. that will be able to continuously monitor compounds in the interstitial fluid. Initially, they're developing the sensor for vancomycin, but obviously there are lots of clinical applications for this particular approach. We're conducting the first time in human studies at the moment, but there are a number of clinical studies that are lined up. And the really exciting aspect of this particular approach is this ability to multiplex, so adding multiple analytes onto the patch. So for vancomycin, we might like to add creatinine, so we get a bit of an idea of the potential for nephrotoxicity. And we might also want to add some biomarkers of the clearance of the infection. So I think it's a really exciting space to be working in, and I'm really look forward to hopefully very soon sharing some clinical data from the use of this particular patch in humans. So hopefully I've been able to show you today that there are several challenges with the more traditional therapeutic drug monitoring approaches, particularly regarding the turnaround time of drug concentrations and the complexity of some of that bioanalytical approaches, and the difficulty to conduct therapeutic drug monitoring in a busy clinical environment, and particularly in an outpatient setting. And I think biosensors are a potential solution or another tool in the toolkit, so to speak, to enable not only point of care testing of drug molecules, but I think probably more excitingly, the continuous molecular monitoring and the development of wearable devices that can actually measure drug exposure rather than predict it. So finally, I'd like to thank Professor Kevin Plaxo, who is the inventor of the Aptamer technology, and the individual people that I've been working with for some of these experiments, as well as the folks at Neutromics, who I've got the pleasure to work with and to assist in the commercialization of this particular approach. Thank you.